We are. Hey, everybody, Dr. Rob Silverman here, Amazon best-selling author, Inside Out Health. I've got co-founder Dr. Tim from Ciro Up here, and I'm excited to have him. It was hard to get this guy. I got him. I got him because everybody out there wanted to hear about rotator cuff injuries. But before that, Dr. Tim, it's my pleasure. Thanks for coming on.
Thank you very much, Dr. Silverman. I appreciate the opportunity to come out today.
Well, I'm happy that you're here. You know what? A lot of people want to know about rotator cuff, but could you give them a little background on you?
Yeah, I'm a practicing chiropractor. So I graduated a long time ago. I've been practicing for over 25 years in Illinois. We've got a practice with about 4 chiropractors. We had a multidisciplinary clinic with physical therapy as well. We treat musculoskeletal injuries, and still love what I'm doing and like to share knowledge. A few years ago, I started teaching for the University of Bridgeport orthopedics program, which is now the NSM program. And so I get to see a lot of chiropractors. We're starting to get back out on the road, and it's not all virtual. So life is good.
Awesome. It's great. We're going to talk a little bit about your baby, you and your partner, Brandon, and Ciro Up, but we're popping up some questions. Oh boy, I'm never going to hear the end of that one. Oh God, I'm going to have to hide from him in all these virtuals now. Goodness. So we have some questions. People that send questions in because we had advertised it. So the first question is, getting to the meat of the matter, why are rotator cuff problems so common? So I'm going to pop that up for you. And there we go.
I think that one of the big reasons is that so many of our joints are stable. So we see bony issues, arthritic issues with joints that are really stable, like the hip, whereas the shoulder sacrifices that stability for mobility. And that means that the soft tissues are going to have to carry the load. They're the ones that are going to take the stress and provide that stability, and they're overworked. I think that a lot of those rotator cuff problems happen because of life, that our lives have forced us from what they used to be of being very active and working in fields and hunting and fishing and gathering to sitting at a desk or treating patients or sitting on our iPhone. And all of those activities are so flexor dominated that it pulls our head and shoulders forward, which is not a happy position for the rotator cuff. That as our pecs tighten up, as our upper traps tighten up, that's going to cause an inhibition of the serratus and of the muscles that stabilize the scapula, and just allow it to get into a position of a funk where it's not moving the way that it should. It's either not stable enough, or it's not mobile enough, or a combination of those. And it predisposes that vulnerable tendon to injury, where the tendon gets pinched and repeatedly irritated, and eventually starts to cause problems. So many of us, once we get to 40 or 50 years old, now have had years of trauma from those bad postures that are inevitable and now turn into something that creates 4.5 million office visits per year.
Wow. So you alluded to something, posture's effect on the rotator cuff, the rounding of the shoulder, the anterior head carriage. So would it be fair to say that posture is a indicator for rotator cuff issues?
Well, I think you nailed it with that one, that we all talk about rotator cuff ruptures. In order to get to a rupture, you had to have a tear first. So 100% of them had a tear. In order to get to a tear, 95% of them started with an impingement syndrome, to where the tendon was getting pinched by the acromion. The other 5% were a traumatic onset. And of the 95% that were from the impingement, 100% of those had scapular dyskinesis, which is a fancy term meaning that your shoulder blade's not doing what it's supposed to be doing. And that's a postural fault, that those patients who have, as you said, the forward head carriage, there's a predictable pattern. So Yanda classified that as upper cross syndrome, that anytime that you have tightness of the traps and the pec, which is about 100.1% of the population, you're going to have the opposite side of that cross, the deep neck flexors and the serratus anterior, are going to be weak. And unfortunately, that's a self-perpetuating cycle. The tighter that the pecs and the upper traps become, the weaker that the serratus anterior and the deep neck flexors become. So we're familiar with the deep neck flexors. That's kind of the stabilizer of the neck. When they don't work, we have cervicogenic headaches, cervicogenic vertigo, and neck pain. When the scapular stabilizers are weak, we're going to have scapular dyskinesis and the whole spectrum that follows down into impingement and rotator cuff problems. So yes, unfortunately, our kids now have postural trainers where all day long they're sitting on something that teaches them how to have a forward head, forward shoulder posture. And that's not happy for anyone.
Yeah, there was a lot of things to unpack there. So great information. So essentially, you went through the shoulder dysfunction continuum, and you were explaining, you went actually backwards to let everybody know the worst to the best. So that was great. I'm going to jump on the scapular dyskinesis, the lack of ability of the scapula to move. So there are some questions on that, but very interesting in that the percentage of people who have rotator cuff injuries. So I'm going to ask a question off the cuff, no pun intended. So many people go to the PT and we're pro PT, and they don't think that the chiropractor is equipped to handle the rotator cuff. Could you expand upon what I kind of just led you to?
I'd rather do something else with it, but I'll expand upon it. I think that PTs are well equipped to deal with a number of problems. In fact, we've had PT in our office, so I'm certainly not anti-PT, that I want to work as part of the team. I want them to be part of the team. When it comes to the rotator cuff, I think that for the majority of those problems that I'm the right person. And the reason that I believe that is because I do the soft tissue things that can be done in physical therapy. I have no problem working out a trigger point in the infraspinatus and the subscapularis. I can certainly teach them how to have stronger muscles of the serratus anterior. We can teach them how to loosen up their pecs. But I have a couple of tools that I think are essential, and the literature tells us are essential, that isn't offered in physical therapy. And number one, that's manipulation, not just manipulation of the glenohumeral joint if needed, but manipulation of the spine. So certainly the cervical spine, as every chiropractor can attest, is very much linked to the rotator cuff. In fact, a study out of Journal of Manual Medicine from the McKinsey Director of Research about a year ago said that 46% of shoulder pain arises from an asymptomatic spine. So a lot of our rotator cuff patients who have symptoms in the shoulder have an asymptomatic spine. Almost half of them. That's something that I'm an expert at dealing with, and I'm confident that there's not another group of providers more than my profession that can deal with joint dysfunction in the cervical spine. We're also going to deal with joint dysfunction in the thoracic spine. That a study maybe 6 months ago said that mobilization of the costovertebral joints in the upper thoracic area has a marked impact on the amount of subacromial space. So these impingement and rotator cuff problems happen because there's some dysfunction or some lack of space between the acromion and the humeral head. And my spinal manipulation, both the cervical and the thoracic and costovertebral manipulation, can actually help to improve that space. So I'm going to address not just the soft tissue components and the symptoms, I'm going to address what's happening from a mechanical standpoint in the spine, as well as give that patient the ADL advice. So for certain things, I'd love to send my frozen shoulder patients to a physical therapist. I think they're much better apt to have success with that. They can spend an hour loosening that up and teaching the patient how to do the exercises, counting sets and reps. If you have a condition like a rotator cuff that is very dependent upon what's happening at the cervico-thoracic junction, you better involve a chiropractor.
I agree. I believe that what we do, there's synergy. And again, one of the things that enables us as chiropractors to stand out is our diagnosis and the ability to manipulate or adjust the joints. And I'm going to encourage everybody listening, feel free to ask a question. Dr. Tim wants to ask questions. I've got I don't know that it's a question. She had a rotator cuff partial tear from years ago, and even though it's healed, she still experiences issues in the area. So do you want to address that and possibly why and what some of the things that individual could do to get over that?
Yeah, absolutely. So rotator cuff problems are almost ubiquitous. They're fairly correlate with our age, that if we're 50, we have about a 50% chance of having a rotator cuff tear. And then the big difference there is that's not a rupture. And I know that all the chiropractors listening understand that it's kind of like a horse's tail, and that you can have a partial thickness tear, which is kind of like running a butter knife down the length of the tail so that it opens up into a taco. You can have a full thickness tear, which doesn't mean it's cut in two pieces. It means there's a hole in it, like a buttonhole that you could now look through, or there's a rupture where it's two pieces. So partial and full thickness rotator cuff tears are about equal to our age. An 80-year-old has an 80% chance of having a tear. and those are asymptomatic. So there's a huge chunk of the population who has some of those fibers that are disrupted, but don't know it. When they become symptomatic is that when the patient comes to see us or their primary care physician, a physical therapist, or a surgeon. And so the management of that is going to address the things that are causing symptoms and get it back under control. But if we took an MRI of it, we'd see the same tear that was there before. So the symptoms are managed and they come and go. I think the crucial aspect of that is to recognize that, like so many problems, whether it be a migraine or a lumbar disc lesion, that it was a cumulative process that overflowed the glass. And when the glass overflows, it has symptoms. So for a migraine patient, they ate the wrong foods, they were too little sleep, they were exposed to some flashing lights, and now they have a migraine. For the lower back disc patient, it didn't happen in one instance. They didn't bend over to pick up a pencil. They had a bad workstation and a flexor-dominated posture, and they developed a lumbar disc lesion. And for the rotator cuff patient, they develop that because they've had scapular dyskinesis for a long period of time, because they have this forward head, forward shoulder posture, and because they have a bad diet that the tendon's not being perfused the way that it should be from a vascular perspective. So we do something to bring down the stressors in each of those cases. And all too often, I think we celebrate when we lower that glass of water just a couple of millimeters and the patient no longer has symptoms. We need to be really striving to empty that glass. So you talk about having this rotator cuff tear years ago and it healed. Well, it really didn't heal. You brought down the fluid in the glass sub-threshold. All of those factors that are there, unless they were addressed by teaching the patient how to have better mechanics, how to sleep, what their workstation should be, what types of things they should be doing to increase the vascularization, that's going to be the long-term improvement of that problem. So all of the lingering effects of that problem, like tightness in your pecs and tightness in the short head of the bicep and tightness in the upper trap muscles, and then the degenerative changes that happen secondary to moving your whole shoulder differently because you don't want to abduct your arm, that's going to be symptomatic. That anytime we compensate for a mechanical problem, we can get the job done, but there's a price to pay. That if you lit my office on fire and said, you got to get out, I'm going to break both legs, I'll get out. But there's going to be a price to pay on my hands, and my knees are going to get scraped up. Something's going to be irritated in that process. And that's the case with rotator cuffs. When we don't move our shoulder in a fluid movement, something else is going to be overworked and be symptomatic.
So a couple of things. Again, a lot of great information for everybody. And I can see that more and more people are popping in. So keep giving them the factoids and the, if you will, the realness. It's a word we use where I'm from in the East Coast. Number one, would you say most of these rotator cuff, it would appear, is more cumulative trauma than initial trauma? And number two, that residual thing, what do you recommend to do for those residual shoulders where they're healed, but it's not like it was before?
Yeah, good question. They really do go hand in hand. That, yes, 95% of these are cumulative trauma, according to Dr. Charles Neer, an orthopedic surgeon. And I would certainly agree that at least that many. You do have the occasion where somebody fell down and had a rupture of the tendon, but that's pretty unlikely. And most of the time, it was a weakened tendon to start with. So that tendon had undergone some degeneration and ruptured more easily. Getting rid of those residuals is trying to figure out what led to that in the first place. That what are those triggers that brought that on? And we're finding that so much of this is vascular, that we used to think that rotator cuff pathology was an inflammation, where the tendon became irritated and inflamed, and then the body healed it, and then it would become irritated and inflamed. And in some cases, it just stayed inflamed. And as it turns out, that's not what happens. That if you irritate a tendon, whether it be the medial epicondyle or the lateral or your rotator cuff, your patellar tendon, Achilles tendon, plantar fascia, when you irritate those tissues one time and take the stressor away, yes, it becomes inflamed, the body recovers and goes back to where it came from. But if you maintain that stressor, if you continue to play golf or continue to play tennis, or you continue to have impingement that every time you reach overhead, you're dinging that rotator cuff tendon, it's no longer inflamed after about 3 days. It transitions from an inflammatory problem to an uninflammatory problem. So that tendon starts to become degenerated. It's turning into beef jerky because it's started as inflammation, and that's a costly process for the body. And the body said, you know what? If you're just going to continue to ding this, you don't need me. I'm going to go away. You can figure this out yourself. And it takes away all those inflammatory products. And now we have this degenerated tendon, which is weaker. And that's really the whole cycle of rotator cuff pathology, that it's not inflamed, it's uninflamed. And when it's uninflamed, the tendon is weaker. And when that tendon is weaker, it doesn't do its job. And the rotator cuff's job, especially the supraspinatus, is not just to generate torque, but it's to retract and depress the humeral head. So it pulls my humeral head down away from the acromion and sucks it into the socket. And when that tendon's weak, it doesn't do that. So it allows that humeral head to ride up, which is more insult. So now we have this self-fueling cycle in the process, that the repetitive insult makes the tendon weaker and weaker and weaker, which causes more and more impingement. And so our goal is to figure out, how do we get rid of that dysfunction, which most of the time it's because that scapula is not rocking itself out of the way when I'm raising my arm, or there's some sort of an underlying perfusion issue that we see, that patients who have neuropathies and tendinopathies often have other vascular problems. There was a study maybe 8 months ago that said patients with carpal tunnel syndrome tend to go on or have a higher rate of cardiovascular disease, of coronary artery disease later on. And so it's not surprising that these tiny vessels that supply the median nerve, once they start to become plugged, it's going to start plugging other vessels until finally it gets to the cardiac vessel. So there's a correlation there. There's a correlation between nail dystrophy, that 1 in 5 patients with carpal tunnel syndrome have dystrophic nails or skin, that they have broken down skin or lines on their nails. Again, vascular issues. So neuropathies and tendinopathies are very much vascular issues. And our goal is to get vascularity back to those issues. That's why exercise works for almost everything. That's why nutrition is so beneficial for so many things, helping to improve the vascular supply to that area and the overall health of the area. So I think our big goal is to figure out, how do we get vascular supply back to that? What's causing compression or tension, and how do we get rid of that?
You know, it's a great point, because I think chiropractors, typically when we have a conversation, chiros in general, they'll talk muscle, we'll talk nerve. And I've made a lot of points that we don't talk vascularity enough, because that's the nutrition. That's nutrient ingestion and toxic egress. And you made such a good point on that, how our spectrum really has evolved and grown. And you're speaking about vascularity. And really the great takeaway about the position of the shoulder, the impingement. I mean, a subacromial area, I think it's 1/4 of an inch in a perfectly healthy individual. So there's not a lot of room for error. And you made that a great point. People come in, it's not an uncommon thing to see a rotator cuff. But with all that being covered, one of the questions that somebody had asked, and it's probably a doctor, what are your go-to orthopedic tests for a rotator cuff?
So yeah, we could do a few hours on that one. That is a great question. That I'm really going to look at 3 components, and I'm going to try to identify each one of the components. Is there scapular dyskinesis? Is there impingement? And is there rotator cuff pathology? So we can kind of go up chain. So let's start at the top again from the rotator cuff pathology. If we have somebody who has a rupture, they're going to have a positive drop arm test. So when we let go of their arm, it's just going to fall down. And sometimes if it's a complete rupture, that may not be a painful dropping down, because you're not pulling on anything. So sometimes the grade 3 sprains are more comfortable than the grade 2, where you're still pulling on some sensitive fibers. Now, a paper just maybe 2 months ago told us that the drop arm test is also a good test for the rotator cuff. So when that's painful, it tells us there's very likely some tearing of those rotator cuff fibers. So we can use that. That's a pretty rudimentary test. 2 other tests that are really helpful. One is called the external rotation lag sign. So the way this works is we take the patient's arm back into external rotation and abduction, and we hold it there for them. And when we let that go, a patient who has a full thickness rotator cuff tear is going to drop that arm. So they're not able to hold this full abduction external rotation. That's very sensitive for a full thickness rotator cuff tear. And then the last one is the DIME test. This has probably come out in the last year or so. Again, over 90% sensitive and specific for rotator cuff tears. And it's simply a resisted. So we have that patient take their arm out in a frontal plane and raise it, and then we push it down at the count of 4. And then we have them take it out in a coronal plane and push it down at the count of 4. So if that patient is unable to take their arm up comfortably, or has pain when we're pushing down eccentrically, those are pretty sensitive that there's a tear. So if there's not a tear, then we can step it back one notch and say, well, is there some degree of impingement? And most of the time, those two are going to be both the case. So our top 3 impingement tests are going to be the empty can test, having that patient hold their arm out in front of them as though they're pouring a can out and putting some weight on it, a little bit similar to the dime test, except with internal rotation. We're also going to have them do Hawkins-Kennedy test, having them hold their arm out in front of them and then push down as though a hawk has landed on their arm. And if that causes pain, that's a sign of impingement. And then finally, NIRS test, just standing behind the patient and raising their arm up through that impingement zone between 90 and 120 degrees. And when that causes pain, then we can be a little bit more certain. Now, that's a good test to rule things out, that if you can do NIRS test and there's no pain, there's a low likelihood that there's impingement. And then the last things that we would do is check their scapulohumeral rhythm. So have them take their arm up. And for every 2 degrees that my arm comes up, my shoulder blade should be rocking 1 degree. So if my arm is at 180 degrees, 120 of that should have come from the glenohumeral joint, but 60 of that should have come from my shoulder blade rocking itself out of the way. And if that's not happening and there's pain in that painful arc between 90 and 120 degrees, we're going to do 2 things. We're going to say what happens when we add mobility and what happens when we add stability. So the way that we add mobility is just to stand behind the patient and rock their shoulder blade for them. And so that's the scapular mobility test. And if their pain goes away, we know that patient needs mobility. The second thing that we can do is provide some stability. And remember, when there's instability of the scapula, usually it wings off, that the inferior of the angle of the scapula pops off the thorax. So we're just going to push that back onto the thorax and then glide with them along the way. And when that provides benefit, then we know that that patient probably needs some stability. And a self-test for that is just having the patient pinch their arms together and then raise their own arm. And if they can stabilize by pinching those shoulder blades together and the pain goes away, that's another indication they need stability. So those are my go-to tests.
Great stuff. So it's stability, mobility, flexibility. Can you comment on that real quick? And then I got a question from a pro athlete.
Okay, great. Yes. Sometimes they need both, that a lot of times there's just dysfunction, that there's weakness and a lack of ability, that a lot of times that patient with scapular dyskinesis that we ask to raise their arm and we watch their shoulder blade, nothing happens. And when we ask them to pinch their shoulders together, nothing happens. They haven't activated those muscles for years because their pec and their upper traps have been overactive for years, inhibiting the scapular stabilizers, that serratus anterior. And so making sure that that patient knows how to recruit those muscles is essential in that process. Some of these tests actually work to motivate the patient to perform their home exercises, because that patient needs to understand the importance that I can mobilize your neck and your cervical spine, but you need to either strengthen or to mobilize. So using those tests provides the motivation for what the patient needs to do. And if they can see that when my arm comes up, yes, it's pinching because my shoulder blade's not moving, they recognize the source of dysfunction, they'll much more likely move into that flexibility program that you give them. And the same thing with stability. If they can see that if I could just hold my shoulder blade in all the time, my pain would go away because it hurt when I did this. But when the doc held my shoulder blade in, the pain went away. And when I pinched my shoulder blades together, the pain went away. So we need to teach that patient how to engage those muscles from a natural standpoint, just not artificially. So usually mobility or stability, but there are plenty of cases where they need both. It's just a weak tissue that doesn't move, and they need to strengthen it and learn how to move.
Excellent. So former pro football player Ash Allen, he works for Nutridyne, good buddy of mine. He follows us, and he wanted to ask, and I'm sure working for Nutridyne, that if you would be so kind as to put the protocol up, Asha, for everybody, the best nutrition for individuals, athletes with acute rotator cuff injury. We were talking about that. So here it is in a nutshell, and Asha will follow up. So injuries are broken up into 3 phases: acute phase, the repair and remodeling phase, or the subacute phase, and of course the preventive and wellness phase. So in your acute phase, you're going to use proteolytic enzymes to get cellular debris away. You're also going to have anti-inflammation, so you're going to use your boswellia, your ginger, your turmeric, and your black pepper. For your muscle strains or your muscle spasms or splinting, depending on which you have, magnesium, calcium, valerian root, hops, lemon bombs. The secret sauce, or the jam, as they say on Instagram, pro-resolving mediators. Pro-resolving mediators allow for the resolution of inflammation. They allow for the homeostasis between the initiation and the resolution. So to speak to what Dr. Tim was saying before, our issue is things are a little too inflamed. And he had the vascular component of inflammation, which was great. Pro-resolving mediators will help you with that. Also, vitamin D deficiency. So get about 5,000 IUs of vitamin D. All of that in the initial. Yes, it sounds like a lot, but let me tell you something. And I'm sure Dr. Tim will agree. Someone has a rotator cuff injury, they may not be as concerned and not want to purchase those supplements at the beginning, but afterwards, goodness gracious, they'll wish that they had. And in the subacute, everybody's heard about it. Collagen, multi-collagen, 1 and 3, collagen 1, 2, and 3. There are formulas now that have collagens 1, 2, 3, 5, 10, and 15. So these collagens are going to help it knit. Glucosamine, chondroitin, hyaluronic acid. So those are the things in the injury phase. I think I got another one from him. All right, great. Anybody wants that protocol, it's there. I've got a ton of questions for you. You're blowing everybody up. This is great. So let's pick this one. Real quick, easy. Let's dial it back a little. Shoulder impingement from rotator cuff. What came first, the chicken or the egg, my friend?
Great question. That we always thought that scapular dyskinesis was the whole process, that it started when your shoulder blade didn't work well, it caused impingement, and over time then led to rotator cuff tendinopathy. And that absolutely happens. But there is some newer research that's saying that rotator cuff injuries can also lead to scapular dyskinesis. That once you start having pain when you abduct your arm, you start modifying how that happens. So you disengage the muscles that are responsible to move your shoulder blade, and your scapula becomes dyskinetic. So it can be either way. I think that the majority of the time it starts with scapular dyskinesis, progresses to impingement, and then leads to rotator cuff injury. But we know it can go backwards. As far as the differentiation of those two, if we go back to what we had talked about testing-wise, the DIME test, the external rotation lag sign, the drop arm tests, those are going to be positive in rotator cuff injury more so than impingement. And then the NEERS, the Hawkins-Kennedy, and the empty can test, those are going to be more positive in a shoulder impingement patient. We can also look at this as a continuum, that people will rarely develop a rotator cuff injury without first having had shoulder impingement syndrome, 95% of them at least. And so this takes time, that this doesn't happen to somebody who's 20 years old. They could have a tear, but they're probably not going to have a tendinopathy that's happened that quickly. So we move in through 3 stages of impingement. The first stage of impingement is that there's just some inflammation. It's irritated, and that tends to go away. Once that happens repeatedly, now we start to get a little bit of fibrosis. And then we move into the 3rd stage of impingement, where there's permanent fibrosis, and there's degeneration of that tendon. And it becomes indistinguishable from a rotator cuff tendinopathy because those degenerated fibers start to tear and break down and eventually rupture. So it's just one slick continuum along the way. And a lot of times the same orthopedic test will be positive throughout that journey. But based upon the patient's history, the amount of time that they've had the problem, and then the 6 tests that we talked about can probably give us a good indication. The good news is, it's kind of like any test that we do, that are we going to do an MRI on this shoulder patient? Well, our number one, are we going to find pathology that we're going to manage somewhere else, a red flag? Or number 2, are we going to send this patient out to a pain management specialist or to a surgeon? And if we're not going to find if we don't have red flags that we're going to find pathology, and we're not going to do anything with that MRI, why would we do the MRI? And so the same thing's true with treatment, that most of the patients who have impingement and tendinopathy share a common finding, and that's a degenerated tendon. So all of our treatments are aimed at increasing vascularity. We want to create a controlled inflammatory reaction rather than suppress that inflammation. So all of our treatments now Our thing now in the initial stages, we want to suppress the inflammation. But if it's something that's chronic and now we have beef jerky, we want to stimulate a controlled inflammatory reaction. So all those collagen things that you talked about, getting the building blocks into the system are crucial so that once you stimulate the reaction, there's the right nourishment there that can build that tendon back up into a healthy tendon. We also want to think about what we're doing treatment-wise, that we used to be nice to this, that we would use ice and ultrasound machines and all sorts of things to calm the swelling down. And as it turns out, there was no swelling. And so now all the things that we're doing are trying to initiate a controlled inflammatory reaction. We're using needling, we're using laser, we're using shockwave machines, and we're using dull screwdrivers to scrape the tendon with a factor tool. And then we're giving them exercises, but not just any exercise. We're giving them eccentric exercise. We're going to give them negatives, the most challenging type of exercise. And it turns out that works much better than suppressing that process. And then, as I said, making sure that the patient has the right lifestyle advice and that they have the right nutritional support to allow that tendon to rebuild.
Yeah, again, a lot of great info, factoids, real stuff to unpack. Interesting, again, the vascularity keeps coming up, but you spoke about factor and you spoke about a lot of vascularity. So we have a great question here in what's the role of soft tissue and fascia playing in rotator cuff injury? And I know I had said that I want to talk a little bit about fascia, the saran wrap of the body. And, with the conversation going to the rotator cuff injury, and also the vascularity, I think this is a great time if you could address that for everybody watching.
Oh man, this would be a topic that could go on a long time as well. That fascia, we've learned so much about fascia in the last several decades that people like Stecco. In fact, Stecco has a great video called Crawling Underneath the Skin. If you haven't watched that, there's like a 24-minute version that they dissect fascia. And it's an interesting that this saran wrap really envelopes everything in the body. And it also communicates throughout the body that if you affect fascia in one area, it tends to affect fascia in another area as well. So the fascia and the soft tissues are such components that really that is the core of rotator cuff injury. That the rotator cuff, because the shoulder is so dependent upon mobility, it's dependent upon those soft tissues, that yes, we can see a fracture, or we could see a Bankart lesion, or we could see degeneration of the AC joint or the glenohumeral joint. Most of the time, those are incidental findings, much like what we see in the lumbar spine. We know there's very little correlation between the degree of degeneration and the degree of symptoms in any condition. And the shoulder is no different. So those bony findings are really not what we're looking for. We're addressing the soft tissues. We're addressing how the soft tissues affect the mechanics. And then we're addressing what pathology has happened to those soft tissues that didn't fare well in a bad symphony. That when those 17 muscles of the shoulder blade aren't working in concert, something pays a price. And usually that's the supraspinatus tendon, and then subsequently the infraspinatus and the subscapularis. The subacromial bursa plays a role in that as well. So those soft tissues are the pain generators. They're also the problem generators. And I think that would be the take-home point, to look a little bit deeper, not just what can we do to the tissue that's been irritated, but why did that tissue get irritated in the first place? One of the things that we got from doing our high-level overview of so many conditions, we've summarized the best practice management of 103 different conditions now, and shoulder impingement was number one, by the way. And what we see in that process is that everything's a cycle, number one. And number two, that the tissues are so interrelated with each other that one functional deficit can be so related to all the other problems that when you think about the most common functional deficit, probably, well, not the most common, let's say the most well-known, and that would be hyperpronation of the foot, that it's very much related to plantar fasciitis, but also Achilles tendinopathy, and also knee pain, and also lower back pain. And so when we started doing these overviews of so many conditions, we'd see the same functional deficits coming up again and again and again. That so many things had hyperpronation, and the other things are hip abductor weakness, which is part of lower cross syndrome, or scapular dyskinesis, which is part of upper cross syndrome, the forward head, forward shoulder posture. We also have spinal instability and dysfunctional breathing, which go hand in hand. And almost every condition that we came across had one or more of those 7 functional deficits as part of the problem. And sometimes we focus too much on trying to solve that tissue that's injured and not enough time on trying to figure out what was the underlying reason, what were the functional deficits, and what were the vascular nutritional deficits that led to that. That all of our effort as chiropractors in the past focused on joints and bones, and then we expanded to muscles as well. But we were still very mechanical, and that's crucial. I think the future of healthcare, we're going to recognize that not only are those mechanics so crucial, but we also have crucial components when it comes to the biopsychosocial aspects, that our brains can become very efficient at learning how to process pain, that our brains decide if something's a threat or not. And if it thinks it's a threat, it's going to just ignore it like a ticking clock in a room. There's no threat. All of a sudden it goes away. Versus a tick at night when you're at home alone in bed and you think, what was that? And now you're listening very carefully. And so pain is something that our brain tends to listen very carefully to. So our chronic patients with pain tend to learn how to process pain more efficiently than the rest of us. And that's not a good thing. It leads to chronic problems. So the biopsychosocial aspects, which has a huge nutritional component as well, and the vascular aspects are going to be the other things that we're going to focus on in the years that follow.
Well, we got a shout out from Jonathan. We also have physical therapist, hypertonic pec minor, and myofascial sling imbalances are big contributors.
Yeah, a great point. And so that pec minor, that's so related to the scapular dyskinesis that really there are 4 big muscles that play into the motion of the scapula. And the 2 in the front are the short head of the biceps and the pec minor. And that those attach onto the coracoid process of the scapula. And then 2 in the back are going to be the serratus anterior, which is going to attach on the medial border of the scapula and then onto the rib cage to help hold that scapula against the thorax. And the lower trapezius that we often deal with the upper trapezius, it's often hypertonic, but its cousin, the lower trapezius, is often hypotonic. And so anytime that there's an imbalance in those things, if you take the scapula and we take a bungee cord and tie a biceps and a pec minor onto the coracoid, it's going to rock it forward. And then if we don't have a serratus anterior to hold it up against the thorax or a lower trap to hold it up against the thorax and move it, we're going to have dysfunction. And so scapular dyskinesis is what's causing this most of the time.
Great. I lost all the questions in the chat, so my tech support's helping me now. But one of the questions that was sent in earlier was, how would you differentiate very quickly between the neck and the shoulder? You had said that a lot comes out from the neck, but how would you so I go into the chiropractor, I go into the doctor, I go to the orthopedist. What would we be looking for? So basically, best way to differentiate pain originating from the neck versus the shoulder.
Yeah, I think something that we all face on a daily basis, and I certainly get tricked up as often as anybody else, that so many times I'll focus too much on the shoulder and it turned out to be the neck. And especially early in my career, I focused all on the neck. In fact, prayed that everything came from the neck because I wasn't very good at treating the shoulder. So I think a couple of signs. Number one is, what's the range of motion? That when the patient says, oh, my shoulder's hurting. Well, how's your range of motion? Yeah, it's a little uncomfortable. That's not a rotator cuff. That rotator cuff has a painful arc. They don't like to move their shoulder. They definitely don't like this. So when our patient says, yep, I kind of sleep like this, they've told us that's their neck. They're taking stress off the brachial plexus, because an impinged shoulder certainly isn't going to like this position. So their range of motion, where they like to hang their arm, is a big key. And surprisingly, one test called the arm squeeze test is pretty sensitive and specific. I love this test, and it's this complicated. And I can do that again if you need. It's a matter of squeezing the arm. And so what that does is it tells us, could this be coming from the cervical spine? That when I squeeze my arm, if I had a rotator cuff problem, it's probably not going to hurt because I'm not touching any of the muscles or irritated tissues. But if my shoulder pain was arising from an irritated cervical nerve root, everything that's attached to that cervical nerve root is going to be irritable as well. And so if I squeeze that muscle hard enough to create a little bit of ischemia to the nerve underneath it, it's not going to appreciate that. It's irritable. So when we do an arm squeeze test where we kind of squish the patient's arm with enough force to just take the color out of it for a second, it's going to give us information. Could this be coming from the cervical spine? So I love the arm squeeze test combined with the patient's history and what's their range of motion like.
Great answer. Now, what's interesting is everything you've shared, it's right off the top of your head. It's because you created this thing called Ciro Up. And I'm a participant. I'm a member. I love it. I wait for Sunday morning. I stay there every morning. I get up. I look at my little newspaper and boom, it comes in. So could you tell everybody what it is and how they could get in touch with it? And I'm going to give you right now an unadulterated testimonial. I use it all the time. I love to read. That's the one thing I can tell you that has given me more information in the musculoskeletal light in one area than their video and their references and their citation weekly. So it's all yours now.
Well, thank you. I sure appreciate that. We developed Ciro Up because I didn't know enough about shoulders. That I had a patient who failed her treatment in the fourth visit. I said, Debbie, where's Mary at? And she said, oh, Mary's not coming in today. She said she's not feeling any better and she's going to go see her doctor. And anybody who's had that feeling knows that really stinks. And I decided I needed to learn more about the rotator cuff. So we dove in, and then we dove into a couple more conditions after that. It turned into a big project. So Ciro Up is a knowledge transfer database that we have an online site that you can access 24/7. You can go to it to find out what is best practice assessment and management and home exercises and ADLs for the 103 different conditions and growing. But more importantly, you can transfer that information to the patient. So with a couple of clicks, I can say that this patient has a cervical disc lesion and carpal tunnel syndrome. And automatically that patient then gets emailed a report saying, here's what's wrong. Here's what I'm going to do with descriptions of each of the treatments that I'm going to use. Here are the things that you need to do, all the things that we forget to tell the patients. And then here are your exercises, including video demonstrations. And then we measure the outcomes from all of our providers. We now have a couple of thousand providers in the system. And we measure those outcomes and say, who truly has the best recipe and how do we improve our recipe? So we're a team that's working together to make that better and then market those outcomes to the people who matter. So you can check out Ciro Up. We have a weekly blog that comes out every Sunday. Thank you for giving that the plug, Rob. And that's free for everyone who'd like to read it. Simply go to chiroup.com and click on the blog. And then each week we'll send you whatever new test or treatment or thought processes come out, Dr. Steele and I. And then I encourage you while you're there to click on the free trial button, because that'll give you access to about 100 times more information as far as what to do to manage the case and how to deliver that to the patients and become part of our community that's really trying to advance our profession into the undeniable best choice for patients and payers alike. And we'd love to have you on board. Yeah,
I'm going to expand a little on what you said. What's great is I have a computer in every room. So when my patients come in, you've got some really evocative type of videos. One of my favorite one is the one when you talked about the disc. So everybody always thinks a disc is like jelly, and it's only 20% jelly. It's more like 80% water. So when you actually see the pig's disc and you're able to talk to the patient, I know this isn't rotator cuff, but we're musculoskeletal today, and you're able to show that it's liquid and it's not the pressure, and it's more the liquid and chemical irritants where they're not getting from the other practitioners. The epiphany that the patient has, say, wait a minute, it's a chemical irritant, it's inflammation, it's lack of vascularization. I thought it was a muscle that just didn't contract. So those things are really valuable, and I applaud you and thank you for making it better for me to educate the patient, because for all of us, education is a critical element to optimization of our outcomes and success with the patient. Sharing the information. We do podcasts. You probably see me looking down. There's people are texting me now. They won't even answer the question. They're saying, this guy's blowing it up. This is great. I wish I saw it from the beginning. By the way, first of all, feel free to ask a question. Secondly, you can watch it again and you can actually download the video. So I really wanted to say that the videos, the education is critical. Having said all that, and I know that you talked about the exercise, What type of home care and ADL advice is most useful for rotator cuff injuries?
Another great question. Probably one of the most important things that we can give our patients, and we kind of learned that here during the pandemic, that a lot of times our advice had to be over the phone and through telehealth as opposed to the hands-on. And now, fortunately, we're able to move back hands-on. But I think that we learned that that advice really can make a major difference in the patient's life. So the things that I want the patient to know, I want them to know how their workstation should be set up. I want to get them out of their forward head, forward shoulder posture. So when that patient is sitting at their workstation, a lot of times their computer will be pushed way back so that they have plenty of space in front. Well, that's just going to pull their head forward because our eyes have a focal distance and it's going to meet that focal distance. So bring that computer closer so that your head is pushed backwards. Make sure that the mouse is at a level that your shoulders can relax, and that's where things are going to hit. So I'm going to change their workstation for them, probably number one. I'm also going to make sure that they understand the importance of a proper sleep position, that they shouldn't have a pillow that's too thin or too thick, that they can be in a neutral position, because a lot of times patients with rotator cuff tendinopathy or any vascular issue, whether it be a carpal tunnel syndrome or a tennis elbow or rotator cuff tendinopathy, have problems at night when there's a lack of blood supply. Our heart rate goes down a little bit, the pressure is down, and so now all of a sudden they start feeling that. And a lot of times it's positional, that if you're sleeping on that shoulder and pushing that the glenohumeral joint together, pushing the humeral head into the acromion, you're choking the tendon that lives in there. It doesn't like that. But when you're sleeping on the opposite side, then you drag that arm across your body, and now you're creating a traction. And whether it be a tendinopathy or a neuropathy, it doesn't like compression. Blood supply goes away when I do that. And it also doesn't like traction. Blood supply goes away when I do that. So teaching that patient how to put a pillow underneath their arm, between their body and their arm, to keep their arm in a neutral position as opposed to dragging it across their body, and helps. And teaching that patient how to get a little bit more blood flowing, that if they get out throughout the day and get a little bit of exercise in, that's certainly going to help things. If they have too many pounds, we got to get those arteries cleared out. If they don't have the proper nutritional support to maintain the changes that we're trying to make, then we're going to do that. And probably most significantly, teaching them a progressive loading program that gradually ramps them up one notch to challenge that tendon into a controlled inflammatory reaction. If I push them too hard, I'll know at nighttime, because their nighttime pain will return. So anytime we're treating a tendinopathy and they start to complain more at night, we need to step it back a notch. And if they don't complain, then we step it up a notch. So trying to make them an active participant in their recovery, recognizing that, yes, my spinal manipulation and soft tissue work is essential, but what you do at home may be more essential.
It's very funny that we'll say that we see them for 15 minutes to 45 minutes, depending on how we practice. What do they do in the other 23 hours? Patients come in and ask me all the time, are there any exercises I can do? Now, granted, they say it's only 6. Can I have like 60? And I'm like, well, can you do the 6? I mean, you laugh because we must have the same patient, even though I think you're in Missouri, Illinois, and I'm in New York, but they must drive and they get to you the next day, but more so than that, what's fascinating is for the chiros listening, they want these home exercises. People want something to be done. You want them to do something at home, because I was I'm taking a course and they were talking about patient mapping. And I just don't like the term because it seems like it's a flow chart and a patient's a mouse. What I like to call it is collaborative patient journey. And part of the collaboration is inspiring them and giving them the stuff that you're giving me that I pass on to my patients. And that home exercise, those things, not eating gluten, let's say, not doing a sit-up and doing a plank, moving her arm, just like you said, that's the secret sauce. And that's really where the young chiro can really help themselves to get to the experienced chiro like yourself. I'm not trying to cut you off. I got a great question. I'm going to go for it. It was about frozen shoulder. I know you said something about the PT, but you know what? I think you're up to the task. None better than you. And here it is. She's seeing patients with diabetes, frozen shoulder. What treatment options are available?
So, that connection, diabetes and frozen shoulder, is a direct link. There's 6 times greater likelihood of developing a frozen shoulder if you're a diabetic, especially a type 2 diabetic. And again, we're dealing with vascular type of issues. So frozen shoulder is something that goes through 3 stages. It goes through a freezing stage, a frozen stage, and a thawing stage. And unfortunately, on average, that takes 18 months. I find that once patients get into the frozen stage, you're in. It's kind of like the migraine. Once you have it, there's not a lot you're going to do to get rid of it. And there are things that we can do to speed that up. If we can catch that patient in the freezing stage, and these patients come in with a rotator cuff look a lot of times because that's how it starts. There's usually something that's limiting their motion. It hurts to raise their arm, so they don't raise their arm, and then it turns into a gross dysfunction. And so if we can catch them in a freezing stage, I like to get that patient into a physical therapist's office very quickly. I like to make sure that they have the proper nutrition support. And at times, there may even be appropriateness for a corticosteroid injection. I don't think there's much appropriateness for that for a rotator cuff tendinopathy because we're trying to create inflammation, not suppress it. And there's a lot of data to say that doesn't work. But when it comes to an adhesive capsulitis, maybe that is appropriate in certain instances. So I like to get them into co-management. And I'll be honest with frozen shoulders is I source that out, that I believe there's somebody better than me to manage that. And I'm not going to manage it second rate. So we send them to the physical therapist and they do a tremendous job with that one. I think that they're better. But as far as the conservative management, they've got physical therapy, they've got pain management specialists, and they've got chiropractors. And if your style of practice accommodates what it requires to get mobility back into a frozen shoulder, fantastic. I think that you can do it as well as anybody else. My style of practice doesn't accommodate that. I can't count sets and reps for 45 minutes.
I hear you. Having a lot of frozen shoulders that come in here and with an impetus, living in the Northeast of can you fix it yesterday? Yeah, those outcomes aren't going to occur that much. I will say, like you said, it's an 18-month period. There are instances that it's been great. You hit the home run. And unfortunately, a lot of them are looking at surgery as an option. Not so sure that that's a great answer. One of the things some data really shows it to be robust is low-level laser's done a great job because it stimulates the healing process at the cellular level. But agreed, diabetes. And again, we don't want to get off too much off rotator cuff, but any kind of blood sugar dysregulation may be the most inflammatory issue you could have. And you've made some great points. We've talked about vascularity. We've talked about fascia being a leader. So if I can extrapolate and put it together, studies have shown that musculoskeletal injuries, the presence of chronic disease after, if not addressed, has prodigiously increased. So when you go to the chiropractor, the musculoskeletal expert, you have to understand that, well, it just doesn't hurt. And it's just it's just a little tennis elbow over here. It's just shoulder. Hey, can you fix it? You're not just fixing that area. You're making that mark and fixing the body from the inside out.
What a great point that those early problems, the tendinopathies and the neuropathies, give us a hint that there's probably more cooking than a tendinopathy and a neuropathy, that you're in the early stages of all of those types of problems of diabetes and cardiovascular disease. And there's data to support that.
Yeah, we got another one. Jerry Gray, she was sent to vascular by orthopedic for thoracic outlet, and he's diagnosed by vascular as a rotator cuff injury, back to the orthopedist. Well, I'll leave you with that one. I'll just say better off with a rotator cuff than a vascular issue. But it's interesting how everything's just resonating to you in what you said as far as the vascular.
Yeah, and sometimes the TOS, and I guess you're talking about maybe I doubt that you're talking about an arterial TOS because that'd be an emergency. But TOS can come in a number of varieties. It can come in arterial, vascular, or a neurogenic. And as chiropractors, by far, we see neurogenic the most common. Vascular is going to be less than 1%. And most of the time, those TOSs are going to cause numbness and tingling into the ulnar nerve distribution, 90% of cases. But they can cause proximal symptoms too. So sometimes it can get a little bit confusing and get into the shoulder. And a lot of the dysfunction that brings TOS into play, which would be tightness in the pec muscles, tightness in the scalene muscles, those are the same things that play into the shoulder blade dysfunction. So it can get messy from time to time, but differentiating the TOS and the rotator cuff should be fairly clinically straightforward.
One quick question about the proteolytic enzymes. Would proteolytic enzymes help with frozen shoulder? I think Dr. Tim said it best. If you get it before it's frozen, all that stuff's going to work. Once it's frozen, just think of it like icicles grabbing into your humerus. But one thing about the frozen shoulder that I'd like you to expand upon before we let you go is, what are some of the outcomes after frozen shoulder? For instance, does rotator cuff injuries increase? Are there more impingements? So what's that secondary and tertiary injuries that occur from the rotator cuff, frozen shoulder?
Yeah, great question. The answer would be yes, because you've learned dysfunction. You've learned exactly how not to move your shoulder. You've learned how to compensate by elevating your whole shoulder girdle and recruiting your neck muscles. And those muscles from the frozen shoulder, the serratus, hasn't moved in a long time. And so if you didn't have a rotator cuff problem preceding the frozen shoulder, you probably will afterward. And fortunately, most of the people who successfully manage frozen shoulder are well aware that you need to be managing all those dysfunctions. So if they're seeing a physical therapist or a chiropractor, they're hopefully getting the mobility back to the shoulder blade as well as the glenohumeral joint, which is the culprit of that frozen shoulder. But yeah, the sequelae are numerous, that any time that we've had to change something, those compensations don't come without a cost. So somebody's going to pay a price.
So essentially, and this will be our last point before we wrap it up in a nice tight bow, essentially you're saying they've learned an improper movement, and even after that, they can come back to you or somebody like you, and you can, we'll use the term, engram the proper movement.
Yeah, great point. That throughout our lives, I think most of us start with movement pattern A1. And then because of the chairs we sit at school, and because of who knows what else is going on, we develop pattern A2. And then that starts to lead to problems that we develop pattern B1 and then B2. And before we know it, we're at movement pattern Z712. And we've got to whittle those back to try to get that patient to movement pattern A1. That if you look at a professional athlete like Asher, his movement patterns were probably really good. And that's why he was a professional athlete. But most of us don't have that level of attention. And so we let those movement patterns go. As chiropractors, we do have the ability to identify those bad, faulty movement patterns, the functional deficits, and then things that are more subtle than that to help that patient get back to A1, which is where health comes from.
Absolutely. So there's a lot that we can do. I think what you've done so greatly is, other than represent the field in that erudite type manner, you're also showing that chiropractor, yes, we adjust, but we do so much more, and we're specialists in all the joints. And what was most compelling that I got from today was, hey, that's not something that I think my skill set sits best. Clinical outcome will be better over here. And you were willing to send it out because you know what the knock is, if it's a knock. Well, once you go to a chiropractor, you always do. And I always look at them and say, you're not going to come 3 times a week for the rest of your life. You will want to see a chiropractor for perpetuity. The question is it once a month? Is it once every 6 months? What it is to maintain your musculoskeletal health. So before we wrap it up, a couple of things. Tell everybody how they can get in touch with you, and give them 3 things before you sign off so they don't get a rotator cuff injury.
3 things. So number 1, try to make sure you're offsetting the forward head, forward shoulder posture. Set up your workstation properly and work on muscles at the gym that strengthen the intrascapular muscles. Doing things like low rows and reverse butterflies and things that move your shoulders back, which is unnatural because we don't move our shoulders back very much. Number 2, stay healthy. Keep the blood flowing. That if you can get daily aerobic exercise, we know that helps everything from plantar fasciitis all the way up to depression. And so making sure that we keep that blood flowing. And number 3, making sure that your body has the right components in it, that the building blocks are there when things need to be solved. And if you have questions, you can get a hold of me, tim@chiroup.com. And I invite you to visit our website, chiroup.com. Definitely sign up for the blog, and I hope you'll check out a free trial. We'll do our very best to make it well worth your while.
Well, it is well worth your while. And somebody just texted me. They wanted to know if you could send a link with your team to either some rotator cuff exercises or a video on somebody doing some rotator cuff exercises, if that was possible for you.
Yes, absolutely. So we have a rotator cuff guide that if you email tim@chiroup.com, I'll have our team send out our rotator cuff guide, which has all of the assessments and treatments. A faster way to do that, if you'd like to access it instantly, is to go to chiroup.com, click on free trial. Within about 60 seconds, you'll be into the site, and then go to the rotator cuff protocol. And you'll be able to access all the videos, all the assessments, all the treatments for that and 103 other conditions. And you'll also be able to prescribe a report to your patient. So you can email your patient all of that information. So you can contact me, but I'd invite you to try it yourself. You'll be able to get all that information downloaded and sent out in a matter of a couple of minutes. And then once you're in, it's seconds to send that to a patient.
Well, I got to tell you something. It was well worth the time. I wrote so many notes now. I'm going to ask you for some of the citations and some of the videos. It was a great edification for me. I'm getting a lot of great feedback. We definitely have to have you on. And maybe we'll have the other guy on also. We'll give him a shot at it. And Brandon, you were great. Thanks so much. I hope to see you soon.
Thank you, Rob. Thanks for having me. I enjoyed sharing with you today.
It was great. Have a great one. We'll see you soon.
Thank you. You too.